Good afternoon to my MBA family. This is probably one of the most significant webinars that we could have right now. COVID-19 vaccine, the impact on the African American community. The reason why it's so important is because for all of us, for all of our families, for our loved ones, for our elderly, for the healthcare workers, for the least of these, those who didn't have a choice but to work during COVID, finally, there's a vaccination that, or two vaccinations that one could take that people feel could be a solution. But there's so many questions, so many doubts in the African American community in particular, and we've got to talk about them because when I talk to people throughout the country, whether it's about police brutality, COVID, or election suppression, all of these pandemics that we're experiencing really revolve around COVID. And in our community in particular, there's a great deal of uncertainty. We always think back to the Tuskegee experiment, the syphilis experiment. One of our past presidents, Fred Gray, was a lawyer for those plaintiffs. And even if it's not real or it's not palatable for us to do those comparisons, for people in our community, they remember that experiment. They remember other experiments. And they also know and feel some kind of way about how African Americans are treated by some in the medical profession and are fearful of taking this vaccination. And of course, if there's not a buy-in, then that could impact the entire effectiveness of this vaccine. So today we're here to discuss some of the myths, fact versus reality, whether this is a vaccination that is the cure or whether it's just the first step of multiple steps that we need to take to protect ourselves against one of the most deadliest viruses that we've seen in modern day history, decimating so many Americans, destroyed so many families, and infecting, we're right now reaching higher numbers than ever in terms of the impact on our communities globally. So thank you so much to the president of the National Medical Association, Dr. Mcdougall. I want to thank you for your extraordinary work that you're doing for our communities, actually for the country and for the world in this space. And we are particularly proud and honored that we have a partnership with the National Medical Association that we forged a long time ago, way before it was popular or in vogue to talk about COVID. And we had this COVID manifesto. So thank you, Dr. Mcdougall. To Dr. Blackwell, I want to thank you for your participation and for all of the information that you are about to impart to our members and those who are, and our guests who are listening to this. And also the same, I say that to, I'm going to say Professor Carl Coleman, because the three of you are going to be in a position to answer so many questions of our members, of our guests, and our community. So I want to thank you in advance. And to our MBA family, I feel as though we have reached a milestone. So many things have happened, but we have reason to be optimistic in the future to be able to address this deadly disease. And we have to look to our experts to educate us on the pros and cons and on the next steps that we should take. And to Yuri Walker and the health law section, and to my other MBA family members, Kyle and others who have put this on, I want to say thank you in advance if I don't get a chance to do that a little bit later, for just your time, energy, and effort in ensuring that we are always on point at the National Bar Association.
Thank you, President Hoffler, for your remarks. And I just want to take a moment to introduce our distinguished panel that we have today for this very important vaccine. My name is Yuri Walker. I'm a member of the NBA COVID Task Force and also the Vice Chair of the NBA Health Law Section. Our first panelist is Dr. David Blackwell. Dr. Blackwell is a Senior Director in Drug Safety Research and Development with the Worldwide Research, Development, and Medical Division of Pfizer, where he serves as the General Toxicology Lead. Dr. Blackwell is proud to contribute to Pfizer by assessing and communicating safety concerns throughout the life cycle of drug candidates. In 2009, Dr. Blackwell became a Pfizer Global Health Fellow and was assigned to the St. Hope Foundation in Houston, Texas, as a clinical research developer, where he assisted in finding research opportunities and strategically organized, coordinated, and implemented clinical trials in the Division of Infectious Diseases and HIV medicine. Dr. Blackwell has been a member of the Animal Drug Section Safety Expert Working Group to the Animal Health Institute. Dr. Blackwell is the current lead of the Pfizer Global Black Community External Impact Pillar, with a focus on addressing social inequities through strategic external partnerships and programming to improve the community's ability to reduce healthcare disparities and building relationships within our communities. He did his pre-veterinary work at Southern Illinois University with a focus in chemistry and earned a Doctor of Veterinary Medicine degree from Tuskegee University School of Veterinary Medicine, and he has a graduate global health certificate. He also has a Master of Public Health from the University of Massachusetts. He enjoys influencing and working with talented scientists and is known for his loving and caring for people. Our second panelist is Professor Carl Coleman. Professor Coleman is a professor of law at Seton Hall University Law School and a core faculty member of Seton Hall Center for Health and Pharmaceutical Law and Policy. Before joining the Seton Hall faculty, he was executive director of the New York State Task Force on Life and the Law, an interdisciplinary commission charged with developing public policy on issues raised by medical advances. He has also served as bioethics and law advisor to the World Health Organization in Geneva, Switzerland, and as a member of the Secretary's Advisory Committee on Human Research Protections in the U.S. Department of Health and Human Services. Professor Coleman received his JD degree magna cum laude from Harvard Law School and holds a Master of Arts in East Asian Studies from Harvard University. His undergraduate degree, a Bachelor of Science in Foreign Service cum laude, is from Georgetown University School of Foreign Service. Our third panelist is Dr. Leon Mcdougall. Dr. Mcdougall is the first African-American professor with tenure in the Ohio State University Department of Family Medicine, and he's the first diversity officer, AKA Chief Collaborating Officer for the Ohio State Wexner Medical Center. He's a graduate of the University of Toledo and the Ohio State University College of Medicine, where he completed a family medicine residency at the Naval Hospital, Camp Pendleton, California, and earned a Master of Public Health degree from the University of Michigan School of Public Health, Department of Health Management and Policy. As a family physician, Dr. Mcdougall has served a mostly elderly population on the Near East Side of Columbus, Ohio since 2001. Dr. Mcdougall is widely recognized nationally for clinical excellence as being among the top 10% of healthcare providers for patient satisfaction and among the best doctors in America. Dr. Mcdougall was installed as the 121st president of the National Medical Association on August 3rd, 2020, during their virtual annual convention and scientific assembly. Dr. Mcdougall was also elected in 2013 to 2015 to serve as the Association of American Medical Society Colleges Group on Diversion and Inclusion National Chair. He is a diplomat of the American Board of Family Medicine and a fellow of the American Academy of Family Physicians. Dr. Mcdougall was elected to membership within the Alpha Omega Alpha Honor Medical Society faculty, and he is a member of the Rima Christian Center and the Association of Military Surgeons of the United States. He is a native of Sandusky, Ohio, and with his wife, Natasha Jones Mcdougall, a Master of Education, they are the proud parents of 2 children. Our moderator today will be Deidre Newton. Deidre, who is a member of the Health Law Section and the NBA's COVID-19 Task Force, will be the moderator for our panel. Deidre is retired as Senior Counsel for the New York City Health and Hospitals Corporation, where her practice area was in patient care legal issues, including consent, privacy, guardian, and mental health law. And at this point, I'll turn it over to Deidre. And thank you for joining us today.
So hello to all the NBA members, and thank you to all our wonderful panelists. I'm just going to give a brief process description. We are going to begin, each panelist is going to speak, and then the final portion of the webinar presentation, they will be speaking to each other and responding to audience questions. So if you have questions, please put them in the Q&A button on your Zoom, and as moderator, I will select among them at the point that we begin to ask the panelists questions. We're going to begin with Dr. Mcdougall, followed by Dr. Blackwell, followed by Professor Coleman. So Dr. Mcdougall, thank you so much for joining us. The question that I have, that we all have, is could you please describe the protocol that led to such quick development of these two vaccines and others that are coming along? Should people believe that they are safe?
Good question, Attorney Newton. So let's start with the methodology. So with the vaccine protocols through Operation Warp Speed for the pharmaceutical companies, except for Pfizer, the enrollment started early in both phases 1, 2, and 3. Phase 1 is typically a smaller group of people involved with helping to determine safety in regards to some of the dosing. Phase 2, there's a larger group of people, maybe a few hundred folks, where that is more refined and additional investigation takes place. And then phase 3 is the clinical phase, where through phase 1 and 2, we've established, or the pharmaceutical companies have established, the dosings required to produce the immunity that would be thought to protect people from being infected with COVID-19. And the initial goal set out by the Food and Drug Administration was to have an efficacy of 50%. Both the Moderna and Pfizer vaccines resulted in efficacy of greater than 94%. In regards to what we have done, the National Medical Association, so we established a task force on vaccines and therapeutics, and it's comprised of pediatric infectious disease specialists, adult infectious disease specialists, infectious disease epidemiologists, members of the CDC Advisory Committee on Immunization Practices, county health department leaders, and others. And since October, we've been meeting with scientists and representatives from Pfizer and Moderna. And we've reviewed the data made available to the FDA and the CDC Advisory Committee on Immunization Practices. And we looked at this through the lens of a Black doctor serving Black people. And we were especially interested in determining if there were any significant differences when comparing the Black participant cohort with other cohorts enrolled. We were satisfied with the enrollment from a diversity standpoint, whereby both of the clinical trials reached a goal of at least 10% enrollment for Black people. So with the 30,000 or so people in the Moderna trial, that resulted in over 3,000 Black folks enrolled in that trial. And then for Pfizer, over 44,000 or so, there were 4,400 or so Black folks enrolled in that trial. So that looking at data with comparing those cohorts and finding with our review that there were no significant differences in the outcomes comparing the groups, gave us confidence in providing our opinion that we support the emergency use authorization provided by the FDA to both the Pfizer vaccine and the Moderna vaccine. Yes.
Can you tell us, when we hear that a vaccine has 95% efficacy, what does that mean?
So that's when you're looking at the group of participants that received the vaccine and comparing that to the group of participants that received the placebo. And once they're out in the community and seeing the numbers of folks who did not get the vaccine, their rate of, or number of those folks who contracted COVID-19 symptoms versus people in the vaccine group. And there was a great difference when comparing the two groups, and then being able to calculate that 94% or greater efficacy in regards to what we've seen thus far, or what's been observed thus far as the vaccines have been rolled out in phase 3 of the clinical trial.
Thank you so much. We're going to turn now to Dr. Blackwell. Dr. Blackwell, can you tell us about future testing for the Pfizer vaccine that you've been involved in developing, and any others that you have information about?
Yes, I'm trying to share my screen. So here we go, hopefully. Can you see my?
Yes.
Okay, great. So this is just an opportunity to talk about what's been published as far as the next steps. So as Dr. Mcdougall just mentioned, the emergency use authorization was given for both the Pfizer vaccine and the Moderna vaccine. For the Pfizer vaccine, it's approved for individuals who are 16 years of age and older. For Moderna, it's adults 18 and over. But currently, there are about 1,000 participants that are currently enrolled in the 12 to 15-year-old age range in a trial that's ongoing at Pfizer. In addition, 16 to 17-year-olds that are currently will continue to be enrolled that were in the initial study as well. So that will continue so that we can get more individuals in that age range. Going forward, there are studies that are going to be planned or that are in planning for pregnant women, as well as for children who are younger than 12 years of age, and for those in special risk areas, particularly immune compromised persons, because that's one of the questions that's being asked. You know, how effective is the vaccine going to be in those individuals? For the Moderna vaccine, the data show that there's currently studies being planned for pregnant women and for children. And my reference is the New England Journal of Medicine. It's mentioned here. So this is information that was provided by each company that was updated in the New England Journal. And I think the New England Journal is going to continue to publish data as it becomes available on these cohorts that were mentioned. So the 1,000 participants that are at the 12 to 15-year-old age range, as well as the continuation of the 16 to 17-year-olds. In addition, I'll just add that for those individuals who are originally enrolled in the phase 3 programs for Moderna and Pfizer, of course, there is an obligation that those individuals will be tracked for at least 2 years to continue to check for safety and other issues that are potentially could come up as people are getting over time, right? Because, one of the questions you asked, of course, Dr. Mcdougall, was the rush that this happened. So the data that was provided to the agency for the emergency approval was basically after 2 months of safety data after the second injection that was given. So that will continue and will be published. Happy to take any questions later.
Okay. Yeah, we are definitely getting questions. So, Professor Coleman, could you tell us how regulation addresses the questions of priority and access? Now that we have vaccines, we have to distribute it in some fair and reasonable manner.
Yes, I'm just trying to share my screen. Are you seeing the PowerPoint?
Yes.
Yes, okay, let me put it into, here's the slideshow, yeah. Okay, I'm going to talk a little bit about the CDC's approach to vaccine priority, and then some of the variations we're seeing in what states are doing in this area. So the CDC makes recommendations to states on how vaccines should be prioritized and as they're rolled out, but the recommendations are not binding. They're just recommendations, and states can choose to implement them or not. And there has been actually quite a bit of variation in what states have been doing in this area. So just to go through the categories that the CDC has recommended for the first wave of prioritization, and that they've only issued recommendations in the groups that you see on the slide. They're probably going to be making further recommendations once those groups have already been vaccinated. The first group, phase 1A, are the people that they identify as the most essential who should be vaccinated first. And these include healthcare personnel and residents of long-term care facilities. The definition of healthcare personnel is all paid and unpaid persons serving in healthcare settings who have the potential for direct or indirect exposure to patients or infectious materials. And that includes administrative staff, that includes anyone basically who's working in a healthcare facility where there is this potential for patient contact or contact with infectious materials. So it's not really accurate to say it's healthcare workers, because you could have people who are working in the healthcare profession but don't have that kind of exposure to patients or infectious materials, and so they wouldn't be covered. And you could also have people who are not healthcare professionals but who work, say, in a cafeteria in a hospital, who would have this exposure and therefore would be covered. So so it's a very particular definition of healthcare personnel. So you have those as the two highest priority groups, and just to emphasize, long-term care facility residents are prioritized because that really has been the center of many of the breakouts of COVID-19. So these are people who are extremely vulnerable, and so they were put in the first line of priority. The next level group includes frontline essential workers and people age 75 or older. So frontline essential workers are people who are both essential and are frontline in the sense that they have direct contact with people, with the public, and they can't avoid contact with the public by nature of their work. So that includes a lot of different categories. It includes police officers, firefighters, corrections officers, grocery store workers, public transit workers, postal workers, people in the educational field. So it's a pretty broad range of people, but the key factors there are that they really are essential, and also that they have this public contact. People age 75 and older, primarily because these are the people who are at greatest risk of serious complications if they become infected. There was a kind of interesting debate when these groups are being identified with respect to which of these groups should have greater priority, if one should have greater priority than the other. Because the argument was that, while it's true that people 75 years and older are at greater risk of serious complications and death if they are infected, many of them are not at a particularly high risk of getting infected because they're isolating at home. While you have essential workers, frontline essential workers, many of whom are younger and would not necessarily face as great a risk of serious illness or death if they are infected, but they're at a much greater risk of exposure because of the nature of their job. And so it's these competing considerations, and what the CDC ended up doing is just putting them at the same level. But initially there was talk about potentially putting one of the groups above the other, and there really was no consensus as to whether that could be done in a fair way. So that's the second group. The third group, phase 1C, is people slightly younger, so 65 to 74-year-old, for the same reasons as the older group, but just to expand it a little bit more. And then people who are younger but above age 16, because as we heard that the tests are only now being done for people younger than age 16. But people between age 16 and 64 who have underlying conditions that increase the risk of serious or life-threatening complications, as well as other essential workers who are not necessarily frontline essential workers. So people who work in, say, information technology, who may be able to do backroom work or work at home where they're not as directly exposed, with there's a danger that if they do become sick, that could really undermine infrastructure. That could make it harder to just keep society functioning. So that's where the priority groups are now. In terms of what states are doing, all states are prioritizing Group 1A as number one priority. When you start getting into Group, well, actually, let me say a few states, even in Group 1A, added some other groups to the top level of priority. So, for example, some states added first responders. So, for example, EMS personnel, on the theory that they're essentially in the same risk category as healthcare personnel. It's just that they're outside the healthcare institution. So they were added. Other states, not many, but a few, added incarcerated populations or homeless populations on the theory, again, that they're exposed to a much higher level of risk than the general population. Once you start getting into Group 1B, that's where you start seeing a lot more state variation. So I would say most states have tinkered a little bit with Group 1B. They're still including those two groups, but they've added additional groups to this level of priority. For example, some states have brought in people 65 and over immediately into Group 1B rather than waiting for a separate stage of 1C. Others have even gone lower to people age 50 and over if they're living in intergenerational housing, where there's a greater risk that they'll be exposed because of someone who's younger, who's going out more, so they're at greater risk. So there's a lot of variation you can see in the different groups. In terms of where states are, that's actually a different story. I mean, most states are still limited to Group 1A. So in terms of where vaccination is happening, most states have not gotten past the level of vaccinating healthcare personnel, long-term care residents, and in these states that have added a few extra categories, those extra categories. There are 10 states, as well as the District of Columbia, that have moved to Group 1B. Only one state, Michigan, has actually made it to 1C. Just a couple of days ago on Tuesday, the CDC recommended that states just all go into all three of these groups now, that they shouldn't wait and do them sequentially, that they should essentially treat these three groups as eligible for the vaccine now. And their analogy was like, when you board an airline, you have some groups that start earlier and then you have the next wave. But the fact that, the first priority group hasn't completely been vaccinated shouldn't prevent at least starting to reach out to the other groups. But as a practical matter, states are really struggling even to do the limited amount of vaccination they've been attempting to do. So a lot really remains to be seen in terms of the implementation of this. Just a few questions I wanted to point out. I mean, there are many questions we could discuss about prioritization, but a few issues to consider. One, why are long-term residents in Group 1A, but not other people living in other types of congregate settings? I mentioned that a couple of states have prioritized incarcerated populations, but logically, there's really no reason that incarcerated populations shouldn't be in the CDC recommendations at the same level as members of residents of long-term care facilities. If we're looking purely at the public health considerations, at the risks to people in these facilities, arguably they're even greater risk because it's harder to separate yourself. On a long-term care facility, you often at least have a room to yourself, or maybe with one other person. It's a lot harder to separate yourself in a prison setting. So, and there are other types of congregate settings too. That this could be an issue. Healthcare workers are given higher priority than other first responders. You saw that healthcare workers were in 1A, other essential first responders in section 1B. And in terms again of the risk that they're exposed to, and their need for the functioning of society is pretty much the same. So that's another question. Homeless people don't appear in any of the priority groups. Some states have added them to the top priority, but they're completely absent from the CDC's recommended priority groups. And they are clearly among the people most exposed, and often because of comorbidities they have, they're most at risk of serious complications. So that's, I think, a glaring omission from these groups. And then there's a question of race and socioeconomic status. And this has received a lot of attention in discussions of prioritization. For example, before the CDC issued its recommendations, the National Academy of Sciences, Engineering, and Medicines made its own recommendations about prioritization. And they said that racial minorities who are worse off socioeconomically and epidemiologically should have higher priority. So they said it would make sense to explicitly prioritize race as one factor, not as a sole factor, but race as combined with socioeconomic and epidemiological factors in light of what's clearly a disproportionate burden of COVID-19 on racial minority communities, as well as people who are socioeconomically disadvantaged in general. The CDC did not recommend doing that. Legally, it probably would be subject to challenge if there were an explicit racial preference given for vaccination. But there are other strategies that people have proposed to take into account some of the disparate burdens of COVID-19 or disparate impact of COVID-19 on different populations. For example, considering factors like geography, socioeconomic status, income level, housing density. There are a variety of factors that could be considered that might be a way of targeting those people who are at increased risk of either getting infected or having serious complications of infection that don't explicitly consider race, but would have the effect of bringing in more people who are disadvantaged because of race. So that's something that has received a lot of attention also. So I also had some issues to discuss with respect to mandates, but maybe you want to hold off on that, and if there are, and we can come back to that if there's time.
Yeah, I agree that it's one of many interesting discussions we may not have time to get to today. I had a question about the role of attorneys. For example, you point out that the incarcerated are at higher risk, or the homeless are at higher risk. Should criminal defense attorneys, for example, be bringing COVID risk up in terms of sentencing or in advocating in other ways to get that group included?
Yeah, absolutely. I mean, and one of the things we've seen, and this depends a lot on the states, is decarceration as a response to the COVID pandemic. And the the idea of putting someone in a prison setting where exposure to COVID is almost guaranteed at this point is, I mean, it increases the severity of the punishment a lot, and that's something that should be taken into account. Now, how that interacts with vaccination is interesting because, you know, if someone can be vaccinated, then I guess the argument for, you know, against imprisonment may be weakened, you know, in the sense that, you know, you're preventing that risk. And so prison is no longer much more dangerous than being outside of prison. So I think that's an interesting issue that defense attorneys would want to take into account, but certainly one way, or whether it's to reduce the likelihood that someone will be sent to prison, or if they're going to be sent to prison, I would think at a minimum, you would want to make sure that they're vaccinated. That just seems like, given that a vaccination exists, putting someone in an environment with such heightened risk without the vaccination, I mean, to me seems, you know, like cruel and unusual punishment.
All right, I'd like to open it up to the panel as a whole. We have a number of interesting questions. And to keep, this one goes back to the science. So I'm just going to read it. I've heard that the vaccine does not prevent one from getting the virus. It only minimizes the symptoms. That means one can have the virus with minimal symptoms and transmit it to someone who has not taken the vaccine.
I can take that one. So the messenger RNA enables the body to produce a segment of a protein called the spike protein, which then the immune system develops antibodies to this messenger RNA produced mimicking of the spike protein. So when one is then, or when the COVID-19 is transmitted via either someone coughing on you or breathing on you unknowingly, then one's body is able to marshal its defense network to fight off the virus that it has been exposed to. Now, and with that efficacy being at about 94%. That being said, we are not quite certain whether one can still transmit COVID infection after being exposed to COVID by someone else after they've received the vaccine. So thereby making it important for us to continue to follow our principles of mask wearing, 6 feet physical distancing, and washing our hands for 20 seconds. And also like to bring up another connected issue to this. We keep hearing about herd immunity. We just need to get herd immunity and then everything's going to be okay. Herd immunity is important. And I think that's speaking more to getting to the point where 75% or so of the community is immunized. So the health system won't be overrun. The health system won't be overwhelmed. Herd immunity doesn't mean that, okay, once we get 75% of the people in the United States immunized, well, we don't have to worry about COVID-19 infection anymore. So I just wanted to connect those two concepts, and I'm trying to explain this as best I can. So that's a good question. I don't know if Dr. Blackwell wants to add to what I've just said or not.
No, I think you did a great job. And the only thing I would say is, again, the efficaciousness of this vaccine is remarkable compared to others, right? Typically the flu's around 50 or so percent. So having in the 90s is amazing. And the reaction that people got when they first heard it was over 90% was just people didn't believe it, right? It's like, oh my goodness, how could it be so efficacious? So that's great, but that still doesn't mean it's 100%, right? So there's those individuals who will get vaccinated who may potentially get COVID-19, and that's just the way that immune systems work. So to the question, it's possible that you get vaccinated and then you do get COVID. Can't explain that exactly, but that's what the data demonstrate, right? It's 94%, not 100%. And whatever Dr. Mcdougall said about the, being able to transmit, again, is still under investigation. We really don't know. But I agree with everything he said about what we need to do to protect ourselves in the meantime. So,
could you speak a little bit about both whether we know what the efficacy is after only one dose of the 2-dose vaccine?
Yes, I'd like to. So,
yeah.
One does not obtain optimal immunity until at least 7 to 14 days after the second dose. And depending on which vaccine one selects, Moderna or Pfizer, that's a 21-day or 28-day wait time between vaccinations. That's what the science says. So all these other configurations on whether one should get the second dose and delaying the second dose beyond what the clinical trials have said is not based on science.
Okay. Okay. One question from the audience. What happens if you're unable to get the second dose of the vaccine in a timely manner? Please discuss for each of the two vaccines.
So I'll weigh in on that again. So make plans to get the second shot, because all these other variations are not consistent with the clinical trial. So I would think that there would be a chance that the second dose, so it's going to increase your chance of getting COVID-19. That's the simple answer, because you haven't reached your full immunity until you get the second dose. So plan for and they give you a card, and they tell you when to come back in for the second dose. So plan for the second dose when you get the first dose. It's very important.
Okay. What are some of the reasons, and this is for all panels, you're hearing from members of the African American community, what reasons are people hesitating? And how do you respond to the hesitation?
So I'd like to start with this one, because I've been on all these town hall meetings and speaking to the community, right? Just like we're speaking to the community of lawyers and attorneys today. So, and if we've included some of these questions in our advisory statement. So I would recommend that all participants here today just go to Google and type out National Medical Association advisory statement on COVID-19 vaccines, and you'll reach a report. So I'll just go down several of these. One of the questions that was posed was that of, if you have sickle cell disease or sickle cell trait, is it safe for you to receive the vaccines? And we spoke specifically to both Moderna and Pfizer about this. And so they're going to break out that data in general when comparing or when looking at outcomes for people enrolled in the trial who had stable chronic diseases. Those folks were enrolled in the trials, and there weren't any disparate outcomes based on looking at the cohorts. Additional questions being HIV. What if someone has HIV? And as we all know, that African Americans and Latinx populations lead the country in new HIV infection rates. So, and actually, persons with a CD4 count of more than 200 and undetectable viral load, they were enrolled in the study. So that's going to be broken out and reported when the biologics license application is put in for both of the vaccines. And another question, I'm just going to keep rolling here, not trying to hog the time or anything. Autoimmune diseases like systemic lupus erythematosus, which is especially more common in Black women. So when they looked at autoimmune diseases as a whole, there did not appear to be any significant serious adverse effects related to the vaccines, and further reporting of this will be with the biologic license application that should occur sometime in the first quarter of 2021. And I'd like to rattle off two more. Pregnancy, right? The question was about pregnancy, and then sterility and fertility. So connect those two. So with the clinical trial and research process, there were reproductive toxicology studies in animals conducted that did not reveal any adverse effects in that regard. And then also received a report recently concerning sterility and fertility. And so that there was a false internet claim that the vaccine spike protein cross-reacts with another protein, succintin-1, that is important for placental formation. COVID-19 vaccines do not contain succintin-1 protein or mRNA encoding for succintin-1. So I'll stop there. I got some more. I told you a bit on all these town halls, Attorney Newton. That's a good question.
Yeah. Well, I think we could go on for many hours, but none of you have the many hours. So we very much thank you for the recommendation. And I just want to say to people that, as you know, the task force webinars are being placed on the BAR's NBA website, and they will be placed there along with the slides and the resources that Dr. Mcdougall just recommended will also be there so that you can do follow-up.
Can I just add a comment? Yeah, I don't think this is just a Black issue, to be honest with you. My daughter, or our daughter, is 19 years old, a second-year nursing student, and she's currently working over the break here at a convalescent home. So she got the Pfizer vaccine a few weeks ago, and not everyone who's working there is taking the vaccine, and they have a lot of reasons as to why they're not doing that. I think a lot of it has to do with the misinformation that Dr. Mcdougall was trying to address, when he mentioned the work that's been done and trying to get the frequently asked questions and the responses that we have based on the science. So the key thing is just, helping people understand the risk and the benefits, right? Because there are risks and there are benefits whether you take the vaccine or whether you don't take the vaccine. And so I think these questions are great because it helps, again, bring it to light what things people are thinking about and why they're potentially going to put themselves at risk for not taking the vaccine.
Can I just add something too, as a non-doctor, no training, non-clinical person, no experience whatsoever. I can just say, as a lawyer who advises some of my clients, small businesses, in one case, a large business, on what their COVID policy should be and what their COVID policy should be as it relates to vaccinations. So this is very dicey. As you all know, the EEOC has issued guidelines that employers can mandate that employees take the vaccination. So they can mandate, meaning they can not make, it's not making it a condition of their employment, but say, our policy at this company is that everyone has to take the vaccination, one of the vaccinations, unless you come up with a medical justification for, why you shouldn't take it, or a religious justification. So there's a lot of pandemonium out there, and there may not be. When the EEOC issues guidelines like that, that means, and they do say that there is a there's not liability on the part of the employer, which there normally would be if they mandate something like that and things go wrong. And so it makes a lot of people who might be in the position where their employers are saying, look, when the vaccine becomes available, you need to take it, are feeling sort of uneasy. So the question I have for you is, what really, if they're not being injected with the live virus, you know, a lot of people are concerned, well, you like with the flu, they think, well, if you're injected with the virus, you're going to get sick. If you're not injected with the live virus, in addition to the things that you've mentioned, what is the real downside to trying it? If it's something that will give you, even if it's not 100% sure, we have a deadly disease, what is the downside to at least trying it and getting both vaccines, even if it only gives you, you know, 94% efficiency is great. But if you're in that 6% that's not covered, what is the downside anyway for anyone of taking the vaccination? Will it make them sick? Do they have a risk of dying? Are they going to contract COVID? I'm just saying from taking the vaccination. I think these are the basic questions that are asked to me on a regular basis, not by learned professionals, but by people who we represent.
Okay, very good question, President Hoffler. So let me, I'd like to take the first shot at this here. So short-term symptoms are commonly experienced following the Pfizer and Moderna vaccinations and last about 1 to 3 days on average, and include pain and redness at the injection site, some fatigue, muscle aches, joint pains, and headaches. So those are some of the common findings. And these, again, are listed in the advisory statement from the National Medical Association task force. You do have those rare findings where someone develops a serious allergy, anaphylaxis, right? And that rarely occurs. And that's why at these immunization centers, people ask about your allergies. And what we're also advising, if persons have history of allergies and carrying around an EpiPen, it may be advisable for them to talk with their doctor and perhaps allergist prior to obtaining the vaccine. I'm just, talking about how best to protect oneself. And if you have there a plethora of chronic ailments out there, I would recommend talking with your doctor to see if you are in fact controlled or have good control of your chronic disease. So to help ensure that it is advisable for you at that time to obtain the vaccine. So those would be some of my thoughts. I don't know if anyone else wants to add to that.
If I could just make a quick comment. I work in a healthcare setting. I work for the Department of Veterans Affairs, and I've been surprised. We've been tracking the data both on patients and professionals, and we have as high as a 50% declination rate for the vaccine, even among eligible healthcare professionals. And what I've been hearing from some of our clinicians is they want to wait until the vaccine moves from emergency use authorization to full licensure. And maybe Dr. Blackwell can speak to, when do you think the vaccines will move from the emergency use to full licensure, and maybe allay some of the anxiety that even healthcare professionals have? And if healthcare professionals have that anxiety and they're talking to their friends that are non-healthcare professionals, then if your doctor friend isn't going to take it, then definitely if you're a lawyer or a teacher, you're probably not going to take it.
Yeah, I apologize. I don't know the exact criteria in which, they're going to go from emergency use to full use. Again, I know the emergency use was based on 2 weeks worth of safety data post the last injection. And so they felt, based on the need of having the vaccines available, that was sufficient to have the information to get approval for emergency use. So my assumption would be, and it's just that they probably want longer duration of follow-up on those individuals who are in the clinical trials to see if there were any additional safety issues that showed up. Because from an efficacy standpoint, I can't see that really changing in the time period that they're going to be looking at this before they go for a full submission and full licensure. The other thing I would say is, just to do my best to reassure you of the rigor of the process, is that there were no corners cut in getting the emergency use approval. And to be totally transparent, just last week, we had the FDA come in-house to our Pfizer laboratories, where we conducted the animal studies for the COVID-19 vaccine. And even though we are in a reduced, situation because of COVID-19. So not everybody who is on site right now, they came anyway. They told us they were coming. They showed up, and they spent a week looking at the data to make sure that everything was substantiated that we claimed, at least from a non-clinical perspective. I'm sure they're doing the same thing in every aspect of the manufacturing as well as the clinical perspective. So again, just to give you confidence that the FDA, even though we worked with them to make things happen as quickly as possible with turnaround, every piece of data was reviewed. And I'm sure Dr. Mcdougall can talk more about, the rigor in which the clinical trials are being reviewed. But at least from a non-clinical perspective, they actually came in-house last week and looked at our data. So they're not, making assumptions that it's all good. They're verifying that with real checks of the data.
And I see that one of our attendees was asking about a vaccine, another one called Novonax Vaccine. I don't know what pharmaceutical company is, but they asked if you could speak about the Novonax vaccine, that this trial that they said Howard is part of. I don't know if either you or Dr. Mcdougall.
So that's Novavax. So right now, in regards to the clinical trial process, as our task force is meeting with the pharmaceutical companies, we're meeting with AstraZeneca now, and Johnson & Johnson, who's producing the Janssen vaccine, which is a one-dose vaccine. The AstraZeneca is a two-dose vaccine, and those are both on the adenovirus platform. We have not met yet with the folks from Novavax, and then yet there's another vaccine candidate being developed by Merck, and that's not expected until the second half of this year. So I don't have specifics about that. I know that's being trialed at Morehouse, also the Novavax. So I can get additional information, but I can't speak to you from actually talking with the scientists. I can speak to AstraZeneca and the Johnson & Johnson.
And another question that, if I could just quickly ask just another question that I hear come up quite a bit is this going to be, especially given that it's a two-dose vaccine, I think a lot of people are concerned that this is going to be an annual vaccine similar to flu vaccine, and wanting to know just how long, even at 95%, how long does that protection last?
I don't think we're quite certain about that yet. I've heard different numbers, but I think that needs to be reported out through the clinical trial process. And I just keep hearing estimates. I don't want to share estimates. I think the clinical trial process, and not only those folks who are being followed for 2 years, the other group of people now that are getting the vaccine and reporting their symptoms via the V-Safe program, and there's another offered by the FDA where they're tracking for any side effects or unusual response and symptoms after receiving the vaccine.
Right, I think we have to let that be our last question and answer. Thank you very much to all of our panelists. This was very informative. And again, the recorded webinar will be available on the NBA website. Thank you all very much.
Can I just say one thing in closing? A little vignette. My parents, 80-year-old, well, we don't like to discuss age, but let's just say hypothetically 80-year-old parents, took the vaccine. They were just like, we just need to take it now. In their group, they just want to take it. They don't get into all these different distinctions. They just want to take it. They took it. My father, who's 6'3", nothing, no symptoms, nothing, perfectly okay. My mother, who's 5'2", headache, fatigue, the 4 things, Dr. Mcdougall, you mentioned, she experienced all of those. But even with all that, they are thanking Jesus that they took it. Because for them, because they have less years ahead of them than behind them, they want to do every single thing that they can to protect and prolong their lives. I make no judgment about what people do individually. I'm just sharing information about what happened in my own family with my very senior citizen parents. So I'm just passing that information on to my NBA family. We have to all be in prayer, but my parents are and their friends were just skipping. After they took it, they were just skipping. They had their masks on. They understand they've got to continue the protocols, but they were so happy because psychologically it was messing with them. That because they feel that, you know, at this stage in their lives, they felt like they were beholden and they feel a little free and they feel protected. So that's just from one person, individual, not even as National Bar president, just as one person, just conveying what the experience was in my family.
Thank you, Dr. Hoffler. Just want to say, just so you know, they say that for those individuals who do have the iatrogenic response, it's usually more severe on the second dose. So just let your mom know that she may feel same or a little bit more for the second dose, but she'll be fine in a few days.
Thank you.
So thank you, and thank you all for allowing me to be a part of this this panel and be a part of the whole opportunity to be in a webinar with the NBA.
Bye.
Thanks to everyone.